Hi dear friends, this is the seventh lecture on myopia progression control program. Now in this lecture I would be taking various interventions for myopia progression. Also mainly it is about how effective combination therapy is. When we combine atropine with defocus lenses, with orthokeratology lenses, or with low level red light therapy, whether we can combine two of any of the two, or we can combine three of them. At this point of time, we always have patients who may progress despite being on atropine, and then we move on to slightly higher concentrations of atropine. There's a possibility, as we have discussed in last 2 months, we have talked about other pharmacological interventions, especially 7-methylxanthine, which is now becoming a source of hope as an alternate to atropine. There have been multiple reports, especially from Europe, that 7-methylxanthine proves out to be a good molecule. I don't know when it will be available in our country, but at this point of time, I think the good news is that atropine 0.01% and now 0.05% would be available. Uh, and defocused lenses are also available at this point of time. Ortho-K is definitely there. We currently do not have red light therapy, and in future there is a possibility that this may also become a very promising non-pharmacological approach in controlling the progression of myopia and even in pre-myopes. Now, when do you intervene? What are the recommendations for intervention? Obviously, if there is a pre-myope who is not progressing, what you have to tell that pre-myope is very simple. You have to tell them more than 2 hours of day outdoor activity or outdoor time. Pre-myopes who are progressors would definitely need some myopia management therapy. Any one of the therapy can help. And then there are myopic patients who are progressors. Now there are uh, more and more evidence, and so now they have come up with a term known as super progressors who progress beyond 0.75 diopters. So progressors are who progress beyond 0.5 diopter per year, and super progressors, not really a term in practice right now, but there have been a couple of articles where they have described super progressors as more than 0.75 progression per year. Now you have to do certain investigations and move on to myopia modalities of myopia progression control modalities. Now these are two important uh, ways of reducing the myopic progression. Why myopia progresses? These are the two key factors, key thought process at this point of time, which we know and believe. This is the landmark article on atropine, which we have exclusively and discussed thoroughly in the fourth class on atropine and atropine treatment for childhood myopia. And this is also the phase 2 report from LAMP study, which has now changed the whole concept of going from 0.01% to 0.025 to 0.05. So at this point of time, these two articles are important because they have changed our thought process as to how to treat and what are the concentrations available and what concentrations we should be using. Now, peripheral defocus lenses, we have already discussed about that also, how peripheral defocus contributes to myopia, that we have discussed, and how peripheral hyperopic defocus, which is contributing to myopia, is being treated and being converted into peripheral myopic defocus with the help of various spectacles. We saw that in the optical control of myopia. So basically, bulk of the optical control is through peripheral myopic defocus, creating a peripheral myopic defocus. And then the third thing, which was in the last lecture on red light therapy. So together, all these peripheral defocus lenses, atropine, and red light therapy, they bring us to three most important ways of treating myopia as a monotherapy. So then it brings us to an essentially important question as to what is combination therapy and which two therapies can be combined and whether they will have a symbiotic action, and whether it is safe to start two therapies together or not. So one of the first things was started was atropine eye drops and defocus lenses together. Now whether they are safe or not. So just 3 years back in 2022, Kaimak et al. They published. There was a talk whether dilated pupil. So when you are using atropine, the pupil size increases. Whether it creates a problem of photophobia, whether it creates a problem of near point of accommodation, that is not a problem with low concentration atropine, but definitely low concentration atropine eye drops would lead to increased pupil size. That is very well known and well accepted. Now, whether when you are using DIMS lenses or whether you are using any other of these lenses, the central aperture is 9 millimeters, and whether it is safe and whether it can be used or not, that possibility was discussed in this article in 2022, and this was followed up by two publications, and now there are multiple publications available on effect of combination therapy. We were fortunate enough to publish one of the first studies from Indian subcontinent on DIMS lenses with low concentration atropine eye drops. And so the difference between our study and their study is very different. In their study, they compared using atropine, combined, separate, and felt that combined DIMS and atropine had much better they were more successful at reducing the progression of myopia, whereas our work was on non-responders to atropine. So our patients were all on atropine, and once they were not responding, they were put on DIMS. So this gives us two important points. One, you can start the two things together as a primary therapy, and still this will be much better than single therapy of atropine or glasses. When you compare these three things, combined DIMS with atropine is better than only atropine and only DIMS or myopia defocus lenses. Now, once you come to the second point, the second point is, if you have started atropine, don't stop atropine, just add the DIMS lenses. So they are not supplementary. As I say in my conclusion in the article, they are not just supplementary, they are actually complementary to atropine. So you are using atropine, and it is the DIMS glasses or the myopia defocus lenses, regardless whether it is DIMS, HALT or CARE, they will be complementary to already using of atropine. So you are using atropine already, and this would just add on to the myopia control. So what it gives us is that if you want to start combination therapy as a primary therapy, you can do that. Nevertheless, if the patient is on atropine, we can always add these glasses, and it is still safe to use the two things together. Now, typically we know the theory, both the things are acting at separate levels, whereas atropine is being used as a pharmacological agent working on dopamine. That is the current theory. And if not just on dopamine, working on choroid, working on choroidal thickening, and everything that atropine is doing is at the level of photoreceptor, at the level of retina, choroid and sclera, whereas the optical one is simply defocusing the light which is getting focused. There is peripheral hyperopic defocus, and they are changing it to peripheral myopic defocus. So both the things are working at different level, and so they are complementary to each other. And typically, based on theory, we can understand that both should work together, and the effect should be better than monotherapy. So that technically also that is understood. Whether it is efficacious or not, this is the article which was published in PLOS One, and they compared the three situations together and compared it with control, and they found that all three of them did work better than control. And you can see that DIMS with atropine was best. Atropine better than DIMS alone. Atropine was better than that, and control did progress. The change of axial length was much higher in control group compared to these three groups. And if you come here in terms of glass change, the glass change was also much better with combination therapy, whereas DIMS and atropines alone had almost a comparable change in axial length, whereas the control group was progressing much faster compared to the three of them together. So yes, monotherapy has a role, but if you feel that monotherapy is not working, or if you feel that they are super progressors, you can start the two things together. So this was from a paper, and this is what we published also. Unlike other papers, we do talk about pre-atropine progression, pre-DIMS progression, which was complementary to atropine, and post-DIMS progression. So the spherical equivalent was 3.9 diopters, and these were 10 children, and despite both the things, there were two children who still progressed more than minus 0.5. So this was definitely less than what they were progressing before. But when we take as a responder or a non-responder, the cutoff is 0.5 diopter per year. So the point was that despite using the two things, both the patients progressed more than 0.5, and together their mean was minus 0.57. And when you take these two together, so that is what when you talk about statistics is an extremely tricky thing. And I was just seeing some of the, if you see this, if you take these two along, you still have a very good result, very good, very tight control of minus 0.39 diopter. But that is where it is worth mentioning that two patients or children progress despite the fact that both were using. So when you remove these two from this, it comes to minus 2.4 and is equal to 8. So there were 8 children who did not progress and had a good control of myopia progression. But when you add these two children, still if you go by mean, it will still come down to 0.39 diopter plus minus 0.5 diopter. So this is what we got in terms of axial length and in terms of dioptric change. Pre-atropine means before atropine was put, and once atropine was put, the difference was only hardly any difference, and hardly any difference in control. So they were true non-responders to atropine, but when we combined the two things together, per year it went down to 0.24, and the progression also reduced significantly when you compared with 0.32 diopters per year. So this was the two things to put together. And if you go to multiple articles, recently there was a report from Scientific Reports where they tried to compare DIMS with low atropine or low concentration atropine, that is 0.01%, and with high concentration of 0.1%, so almost 10 times of that. Obviously, when you use a higher atropine concentration, your axial elongation is much less, but it is quite comparable with low atropine. And if you use DIMS alone, so they had three arms. They did not have they really did not have a control arm. They had just three arms where they compared DIMS with low atropine concentration, DIMS with high atropine concentration, that is 0.125% group. And in 1 year, they found that DIMS with atropine, whether low or high, had a very good control, very tight control. DIMS alone also was working good at zero point 0.3 diopter, and axial elongation was also less than the non-responders. So patients do respond alone to DIMS also, but they do respond much better, and the standard deviation, if you see here, is much higher. So there will be some patients who have progressed much more than in this particular group, where the standard deviation is also pretty low. Once the standard deviation is pretty low, what it shows is that that there are not many highs and lows. So if you see these ranges, you will see that the range will be not very high in DIMS with high atropine concentration versus DIMS with low atropine concentration. So that is between DIMS with and without atropine, high and low concentration. So with our combination therapy, this is some more data on combination therapy. And most of our patients in combination therapy are non-responders to atropine. We have after this particular article, we did have patients where we started using this combination therapy trick, especially in super progressors. So if you have a patient who has progressed beyond zero point 0.5 diopter, like he has gone to 0.75 or 1 diopter of progression, and is an avid reader, does lot of near work, axial length has exploded like zero point 0.4 millimeters or 0.5 millimeters in a year. Those patients, we have started combination therapy at the first go itself. The results are pretty good compared to monotherapy, because we are very much very much afraid that this will progress much faster. But combination therapy does work much better than monotherapy. Obviously, the advantage is that both the effect is independent of each other, and therefore it is symbiotic relationship together is much better than using it alone. And indications, obviously, in super, as I have been saying in this particular talk, that if you have progressors who are progressing very fast as a primary therapy, you can start combination therapy. Atropine non-responders, you can definitely start, or patients who are not responding despite using HALT or DIMS lenses, you can start with glasses if the children are very young, because they may not, you will have to put atropine for very long. If they are putting the drops for a very long time, if the kids are very young, you will have to use the drops for a very long time. So you can start with glasses and add atropine as they are prepubertal, or if you feel that the control is not very good and they are gradually progressing much faster than they should be, you can always add atropine later also. Pre-myopes, maybe you can start atropine first and glasses later, or you can start glasses first. The problem at this point of time is that glasses, there is not much evidence. I think there is one article in which they have been talking about using the glasses in pre-myopes, but otherwise glasses for pre-myopes are not really available at present. So maybe atropine first and glasses later as the time goes on. And there have been a lot of varieties, more the merrier, as we say. Atropine with ortho has been tried, red light therapy with ortho has been tried, atropine with red light therapy has been tried, and I think the days are not far where there will be patients in whom they would be trying out atropine with ortho with red light therapy. So because the mode of action is different from each other, so let us start seeing some of the literature where they have tried atropine with and without ortho. So this is the meta-analysis of 14 studies where they have just compared atropine alone with ortho or with combination of atropine ortho. So atropine alone has shown combination is comparable to ortho alone. Combination combination is definitely better than both of them alone. Atropine 0.01%, ortho 0.01% atropine combined with ortho. So when you use it in combination, it definitely is much better than single drops or single ortho alone. When they combine DIMS with low level red light therapy, so what they have seen, they have compared DIMS, RLRL, that is low level red light therapy, DIMS with RLRL. Now, in red light therapy, they have claimed that in fact there was a reversal, as we also saw in some of the articles, some of the recent publications in AJO 2025, that RLRL is actually reducing the axial length. That is what they have claimed in this particular recent report in Scientific Reports in 2025. They have claimed that in single therapy, they have shown some reversal. With DIMS, they have shown that there is an actual reduction, and minus 0.13 is huge. The SER change is not that much, but again, this particular thing is also comparable. So 0.13 millimeter is huge axial shortening. If it is possible, that's a great remarkable feat. But because both the red light effect is on the on the at the level of mitochondria, it is changing the cytochrome enzyme. Red light therapy is affecting the choroidal circulation, and DIMS is just affecting the peripheral hyperopic defocus. So both the things are acting again at different levels, whereas RLRL is modifying cytochrome C oxidase. It is changing the sterile remodeling. DIMS is acting on creating a peripheral myopic defocus. So both of them work well combination. At this point of time, I think this is DIMS with RLRL shows highest level of highest level of protection against myopia progression. Rather, it is actually showing a reversal of myopia. So huge thing, very promising things for future. Atropine with ortho-K or defocus lenses. So very interesting study. Concentration of atropine 0.01% once at night. 4 groups: ortho-K alone, DIMS alone, ortho-K with atropine, DIMS with atropine. Combination therapy was better regardless whether it is ortho-K or DIMS. Now, ortho-K and DIMS actually work on the same principal mechanism of action, that both of them convert the peripheral defocus, which is hyperopic defocus, to myopic defocus. So, ortho-K and DIMS cannot be clubbed because they have absolutely same mechanism of action. But when you club ortho-K with atropine, or whether you club DIMS with atropine, the combination therapy is almost twice effective as monotherapy. So whenever, if you see these bar diagrams, you can see that when you add atropine, the effect is much faster, much better, and more tighter control. I think one of the small biases, although most of the studies I have gone through and they have critically analyzed their bias, but whenever you use ortho-K, the problem is that overall, not in millimeters, but if you go into refraction, it is extremely difficult. You have to wait 1 month for the effect of ortho-K to go away and then reassess the patient, because ortho-K effectively removes the refractive error completely, and so it is very difficult to know the actual result till the point you wait for the effect of ortho-K to go away and then again see whether it has worked or not. So thank you so much, and very interesting times ahead, because now we have got monotherapy, we have got combination therapy, twin therapies, and triplet therapies, and more therapies would come once 7-methylxanthine joins the group. We will have atropine with 7-methylxanthine, because both of them have a different mechanism of action. We may have atropine 7-methylxanthine with red light therapy, 7-methylxanthine with red light therapy, with DIMS. So multiple things, very exciting times, multiple things into our armamentarium. We right now only had atropine. Bulk of us understand that we just have atropine. That is what, when I talk about myopia in our lectures or in our talks, they say that, okay, what is the treatment? The treatment is only atropine. So now you have atropine, you have higher concentration of atropine 0.05%, you have DIMS lenses, HALT lenses, you have ortho-K. Red light therapy, at least right now, is showing a lot of promise, and 7-methylxanthine is also showing a lot of promise. And this is only the monotherapies. And then once you have combination therapies, and that is where I say that combination therapies are extremely important, because combination therapies makes your permutation combination higher than what you have. So if you have only atropine, only glasses, and only ortho-K, and only red light therapy, you have got around 3 to 4 things. But once you combine, mix and match, you have around 7 to 8 therapies to offer to the patient, and something would click for the patient to control the myopia. So at the end of the day, we are here to stop the progression of myopia, whether it is with monotherapy or combination or triple therapy. So days are not far where we will have some of the observational studies of triple therapies or triple interventions at the same point. So thank you so much for this particular class and for joining the course.